So we're going to get this started strong with a meeting with the WMA leadership. So we'll have with us Dr. Jorge, WMA President, Professor Montgomery, Chair of Council, and Dr. Kloiber, who I think will be joining us shortly, Secretary General of the WMA. They all have impressive experience, many years working with the WMA. I won't go through all of that. I think we leaving more time for them to share their thoughts with us is what's most important here. And so I just wanted to kick this off with you now, just for you to share your open thoughts on this year's WHA. Now, surprisingly, contrarily to the regular formula where we do this before the WHA and we're doing it in anticipation, where we now have the hindsight of doing this after it's happened, and we can have your reflections on how things went. So open thoughts on the WHA, maybe give us your thoughts on how the WMA was involved, how civil society was involved given the peculiar format, and anything else you'd like to share. The format of the session, it's intended to be kind of some time for you to speak, 20 to 30 minutes altogether, and then some time for questions and interactions with all of the people here present, if that's okay with you. Would one of you would like to start?
Actually, hi everybody, wherever you are in the world. Good to see you. And I would rather actually like Otmar to start, because I presume he was the only one who followed the WHA from beginning to end, because I had to leave after Tedros' speech, not to leave Geneva, but to leave the net because I had other obligations. And so maybe, but if he is not online, then with the permission of Miguel, if he is okay, I would like to give a brief introduction on my opinion of the WHA. I mean, the format, it was not a very lucky one for an organization like that, to have 100 plus speakers in 3 minutes or 2 minutes interventions with nobody keeping the time limits, and many people having connection problems, was a rather boring and sometimes astonishing experience. What was extremely embarrassing for me were the appraisals of Tedros Adhanom Ghebreyesus, the Secretary General of WHO, because we all know that there is an underlying political issue which has nothing to do with WMA, which has nothing to do with medicine, actually, which has nothing to do with us, but in the end we are part of it, and that is the underlying conflict between WHO on one side. Actually, it's a triangular conflict, WHO on one side, China on the other, and the United States of America. And I'm not mentioning all the countries who are on either side of these competitors, and that was sometimes a bit, I think, I wouldn't say unnecessary, but it was boring, because I think we have on COVID-19, we have totally other issues to deal with, and not to dabble in this type of temporal politics. My personal opinion, we as WMA are very much concerned about COVID-19. Now you have your own meeting on that later on, but our basic interest is to give WHO, with all the critics we have, with all the problems we have with them. However, if WHO wouldn't exist, I always say you would have to found it tomorrow, because it is a necessary, very necessary organization. And I think it is important that, especially in the COVID-19 crisis, the WHO has the money and the resources, not only money, it's also personnel, it's knowledge, it's interaction, it's travel, it's all this. But WHO must have the capacity to deal with the problems all over the world. And I'm saying that as a citizen of one of the richest countries of the world. We from the rich countries sometimes tend to forget that we may be in some countries just over the first wave of COVID-19, but there is a whole half the world south of the equator, which still has the worst ahead of them. And I think we have to be very much aware that we need an organization of WHO from our own interest, because I mean, pandemia can come back from south of the equator to the industrialized countries very quickly, very easily. So I would like to be very much not only concerned, but to be very much aware of problems that lay ahead of us. That is why we engaged to some extent by stating that we urge the US delegation to not to stop their funding of WHO, but at the same time we stress that there is definitely need for reform. I have been looking at WHO for more than 30 years now, and I feel there is a great tendency to move away from medical, scientific, close to the patient issues to more public health, but not from physicians, more from a sociological point of view. And I think we should, we do need a reform of WHO to come back to medical and important issues, not only on COVID-19, but also on all the other issues which are still pertinent all over the world. So that is a very brief introduction. Yeah, maybe Miguel, you would like to add something else, and then Yassen, I think you're moderating it. You give us a sign by just making sure, and then we'll stop speaking, because
I will.
Old man like Miguel and me always tend to talk too long. So Miguel, that was a very nasty introduction for you, but you have the floor now.
Thank you for your opening remarks.
Well, I have to confess that due to this situation in my country, I even connected to the WHA, meetings during this week. You know that the Amazon was on fire. Now all the country is on fire. We have facing very difficult problems here, literally our crazy president is putting fire in the country. There was a ministerial meeting in the end of April that comes to public yesterday, and it's something that as a Brazilian my feeling is of shame, what I have heard and saw at that video. It's incredible the kind of people we have leading us at this particular moment. So putting this together with the week where we was up in the ranking of COVID-19 cases in the world. We are now second just to the United States, with more than 20,000 deaths, and with the curve almost steep, despite about 50% social distance that we are reaching in the country. Our situation is really very, very serious. I would just make a comment without seeing anything about the WHA, but I was reading in the newspaper even before and during the week what was happening there, but just news that came to the press. I also agree with Monty that such a structure is really something that we need in the world. And maybe I would just make a point on regards of Monty's last, remark. I think that, as he said, if there was a moving from the WHO, from an institution that was more on the side of the bad, doing medicine, and now is an agency that is taking care of the public health, it's, you know, unavoidable that a more sociological approach would be needed, you know, mixed with the biological understanding that we have about diseases all over the world. We physicians, in our practice, we take care of individual people. We take care of people that we have a very personal relation. But I believe that when we try to think about a kind of health policies, it's necessary to take into account other kinds of human sciences, you know, to build a good program, particularly when we are facing a situation like the one we have now, that will need both things. We need, you know, very good guidelines on how to treat particular cases of COVID-19, but we also need, you know, epidemiologists, that we need infectologists that will help, you know, the government to build plans that could be applied to the whole population. And this goes beyond, I think, just the role of the physician. And that, I think, was the movement that I saw in the WHO, also for the same decades that Monty is following their work. So I would just make this, you know, remark on his wordings, but I think that is the situation that I can mention here. I do not prepare anything to say at this meeting, as we have a kind of an agreement among us that Otmar will bring some, you know, our points of view from the World Medical Association. I hope he will join us in some moments more and give you a more, you know, comprehensive analysis of what happened in the WHA meeting during this week. Thank you.
Thank you, Dr. Jorge. So thank you both for your remarks. I think we heard a strong support of a multilateral system, support of basically saying that if there was no WHO, we would need a WHO and we would end up creating one. So I think that speaks strongly to the criticisms that we've seen around how WHO is working. Not saying that it's perfect, but that it's a needed institution. I think we've also heard the importance of interprofessionalism in doing public health and in addressing complex issues that touch upon the medical field, but touch upon other fields and other determinants of health. As a public health doctor, I also work clinically, so I sometimes see patients, but I also work at the systems level, at the policy level, where decisions are taken. And now we see it very much so in the COVID time, where decisions are taken for large groups, and we need that experience of people who will tell us how individuals in a population will react to the things that we suggest. Because even if we tell people wear a mask or don't wear a mask or wear a mask in those locations, well, it's never the case that people do everything that they're told. So we have to have some input from them. I think that that I'd like to now open it to the floor to hear some questions if other people on the call have them. If not, I have a few that I can certainly
Yassen,
throw at you while we wait to see if Otmar
Yassen,
Otmar is connected.
Otmar is there.
Okay, thanks a lot. I was just trying to fill time. Hi, Dr. Kloiber. So Dr. Kloiber, the Secretary General of the WMA. So I'll leave you the floor. We heard remarks from Professor Montgomery and Dr. Jorge on kind of their thoughts around the current situations and a bit about the WHO and global governance.
Yes, thank you very much, Yassen, and I apologize for being late. What I would like to do is I would like to share just some experiences which we had from the Secretariat and from the inside of the organization. as you are all aware of, nearly every in-person meetings have been canceled over the past 2 months. And what we experienced was that in March, our office operations were suspended by a government order in France, which said basically you have to go home and do telework, which we fortunately were pretty well prepared for by setting our systems up for cloud computing and the usual tools which we're already using for accidental conference calls during the past 3 or 4 years. And since then, since middle of March, we have really then suspended the operation of the office and have been going virtual with that. That worked much better than we thought. Interestingly, the number of interactions, especially with groups like WHO, but also other partner organizations, were increased, not decreased during that time. Thanks to the fact that more or less everybody now is going online and is doing virtual meetings. So a lot of meetings which otherwise wouldn't have been possible became possible now and have taken place. So that has increased and speed up the communication quite a bit. You have seen part of this in press releases and common work, which we have done. The last one just 2 days ago in a common publication with PHR on violence in healthcare during COVID-19. And this brings me to some of the topics which we have experienced. Very early on in the pandemic, we have reached out and have posted warnings that PPE would be in low. That was something which we already found out in the middle end of January this year, when we got calls from China, whether we could help to find resources for PPE, which of course was kind of strange to me because, you know, we all know most of this nowadays comes from China. So, and I thought if they have a problem in China to get the material, we probably have one too, which was then confirmed. And we issued a very first press release in January already on the shortage of PPE. To me, it was quite astonishing that most of the governments needed a month to react on this and to be proactive in then buying PPE and trying to get something on the market, which was pretty difficult. The other thing which we found and we reacted on very early from the WMA on was the problem that some of the physicians are engaged in a way which we have to find very unprofessional. Some using this opportunity to sell remedies which are sheer nonsense and quackery. We have physicians denying COVID-19. So our president went out with a statement very early on during the COVID-19 pandemic and saying that we have to stick to professionalism and to truthfulness with that. That is unfortunately going on in many of the countries. Personally, I think our members could do a little bit more in order to at least admonish those physicians who are participating in that. However, I think that is something which we still have to work on. And finally, a topic that we have embraced very much, which I mentioned already, but this is a topic which was actually driven first by our Indian colleagues, and that is violence in healthcare. And here what we have is we have a change in the pattern that is not just an increased aggression and a threshold lowering for violence in general, but what we see is a very stigma-related violence now. And that what we have seen in India is that doctors, nurses, and other healthcare personnel are being attacked by people because the people fear that these persons transmit COVID-19 into their communities. With a low testing situation, with a low protection situation, which many of our colleagues have, unfortunately, this is not completely untrue and unwarranted. Nevertheless, of course, it doesn't justify the use of violence, whether that is verbal aggression or physical aggression or whatsoever. That has reached now more or less to many places over the globe. We have learned from Belgium, from France, that there have been evictions of health personnel, that they couldn't go back to their homes because people were hindering them to come back. And finally, we thought that it was time to join this activity with Physicians for Human Rights to speak out a little bit louder on that. Still a topic that will gain. What we finally are doing, and let me conclude with this, is we have started to gather now all the topics of COVID-19 pandemic, where we think that in the aftermath of the pandemic, we have to continue working on in order to be better prepared for a next pandemic or emergency. You probably know the World Medical Association has 4 or 5 policies which are dealing with pandemic situations and emergency preparedness. A lot of good suggestions in those papers and recommendations. Unfortunately, virtually none of those recommendations has been followed before the crisis, which was not really helpful to improve the situation during the pandemic. But I think that's something which we have to go on. We have to get together the learnings, and I think we have to focus a lot of our advocacy in order to get a better pandemic preparedness in the future. And with that, I would like to stop. Thank you, Yassen.
Thank you, Otmar. So what I heard is calls for the WMA members to do more on messaging to their members to avoid or restrain from doing unprofessional behaviors, a worry about fear causing more violence against healthcare and a change in pattern in the violence, and finally a call to work together and to use what we already have as a WMA. We have lots of policies that could have addressed at least certain of the issues that we face, but unfortunately we're not taking on prior to this. I won't ask any questions right now because I'm mindful of time, and I'd like to leave time for everyone who's connected to see if they can have a chat with you. So I would like to open the floor. If someone wants to speak, just raise your hand. I see Luando Maki. You can unmute yourself.
Thanks, Yassen. Can you hear me? Okay, fantastic. Hi,
Yes.
Mr. Montgomery. Hi, Otmar. Hi, Mr. President. And nice to meet you guys again. Wish it was April meeting would have happened. It's quite nice to always meet the leadership. My question, from South Africa, is we're having now a movement of some parts of our health professionals as the wave is kicking in now. And I'm in Cape Town now, and it's from Joburg. I moved to Cape Town because now the wave is starting in Cape Town. And some people are trying now to use the discussion of conscious objection, regarding treating COVID. And, and from our side, from as a South African Medical Association, we're very clear that, a medical doctor, and our parties aligned that you took an oath to try to serve, our patients, so forth. And I know that it is currently being discussed in the International Code of Medical Ethics, but which has not been finalized. But from the WM leadership, is there any sense of where we stand as an organization regarding doctors who want to possibly consciously object to treating COVID cases for whatever reason that may be? That's just the question I want to just ask for now.
Thank you, Maki. I'll encourage anyone else who has questions or comments or would like to address something to raise their hand in the chat box. You should see that at the bottom. Otherwise, since there's currently no other raised hands, I'll give it back to you, whoever would like to answer. Go ahead, Professor Montgomery.
Yeah, cut out the professor. It's a very difficult question, I think. Very, very difficult question, Luando, which you're asking, because of course there is the right for conscientious objection. None of us has a problem with admitting conscientious objection for reasons of for difficult ethical matters like abortion or euthanasia or these ethical issues. But I think we have two conflicting questions here fighting each other. One is the right for conscientious objections for ethical reasons, but is this really an ethical reason? And the other is the obligation of the physician to treat wherever he can. When we do in emergency situations, we always have obligations. Nobody can and force us, can oblige us to do something where we endanger our own life. But that is something you have to weigh up in individual cases. If you're sent again and again and again into a situation without any PPE to treat actively infected patients, of course there is a stage where you can object. This is my idea on this very briefly, and I'd like to ask Otmar whether he has to add anything to that. But I think basically this is one of the difficult questions which cannot be resolved on a general matter for everyone and for every situation and all over the world. But you yourself have to weigh up between these two basic obligations of a physician, or basic obligations or rights of a physician: contentious objection on one side or objection on one side, and the necessity, the obligation to treat with all your knowledge and with all your capacity. And I think you have to weigh that up individually. Otmar.
Yeah, I'm happy to say it in other words, but basically it's the same. First of all, when being a physician, you don't give up your own human rights. That is very important. This includes also to choose yourself whom you serve and whom you don't serve. So the basic idea that you have to do everything in medicine once you are a physician and have to give up any other right is not correct. So you have choices as well. That is number one. And that sometimes is being forgotten by people who think, well, you are a doctor and therefore you have to work. It's not that easy. Number two is, when you have contentious objection, you have to have a moral ground on which you object to something. To object treating an infectious disease on a moral ground sounds to me very difficult to argue for. And actually, I would not understand how that would work, but that may be something which is my limited imagination, and I have to hear some of those arguments before speaking about that. Finally, the right to choose yourself what you do when you work, for whom you work, may be restricted by contracts which you have, by, for instance, joining the NHS in a country, or having a contractual obligation as an ambulatory doctor or as an employed doctor. So you may be forced to work by that. It is also limited, and that is true also for the contentious objection, by the need to provide emergency help. So when somebody is in danger of losing his life or getting serious damage or having untreatable pain, you have to work. So you cannot just go away. You can only go away if somebody else says, I will take care and I can do this. So if you can hand over to another colleague, then that is possible, of course. And that we do at the end of a shift, for instance, and we go for that. So that is possible. But there is no excuse to just leave an emergency situation. The only point where you have a right, and actually where in some systems you usually are being asked not to do anything, is if there is an imminent danger to your own life. So you don't send a fireman into a burning house. You know, that doesn't make sense when you lose your resource to help. So that is something which is true for physicians as well. And that is something which we have experienced very often in this COVID-19, where people were sent into situations which were absolutely crazy because they had virtually no PPE. And at that point, a lot of the physicians went and did work. And I think they were brave. Maybe it was not perfectly rational to do that, but they were brave, they did it, and they helped. And we have to praise them for that. On the other hand, you cannot excuse somebody to say, well, because he's not going into a situation which endangers his or her own life on a very high likelihood. It's all different when you have the proper equipment. Then emergency help has to be given. Back to you.
Thank you. And Dr. Jorge wanted to comment as well.
I would like to give a comment on another aspect of consensus objection in the current situation. And I think this is very much, you know, consensus objection is something very important when we see that the process of shared decision-making with a better protagonism to the patient is gaining the field for many years now. And sometimes this is something that comes to enhance, I think, the doctor-patient relationship. But sometimes it creates conflicts. And sometimes these conflicts will probably take the physician to face consensual objections to what the patient prefers that has to be done with him. Otmar has mentioned two things during his introduction. One is the use of cracked, you know, medicines like chloroquine or hydroxychloroquine. And the other was violence against physicians and health professionals. We are seeing this here in Brazil very much, you know, frequently, because the chloroquine issue here took kind of part of the political polarization that we are facing in the country. Our crazy president is recommending chloroquine to everybody. And when a minister of health doesn't agree with him, he simply removed the minister of health. And now we have, as an interim minister of health in Brazil, a general from the armed forces. And they just published a kind of orientation to physicians to use chloroquine even in the first day of the infection, not just for serious patients. And as this COVID-19 has no proven treatment, people, patients, families are very much in despair when someone got infected. And I can mention in terms of consensus objection, for instance, in the emergency room of my university hospital 2 days ago, a bunch of 5 or 6 people, family from an elder woman that was in the intensive care unit, with the national flag in their back, entering the emergency room, rushing to talk to the physician who is taking care of their relative, because they, you know, demand that the physician obligatorily use chloroquine to treat the woman. So this links, you know, cracked medicines, physician conscious objection, and violence against health professional. So I would just give this practical example that is going on here, just another phase of what we are discussing when considering what our colleague from South Africa has placed it to us. Thank you.
Thank you. Any other questions from the members? I think someone wanted to ask. Mike?
Yeah, I guess following up on that, Miguel, obviously Bolsonaro and the Trumps of this world are particularly extreme examples, but kind of building on that, if, in the case where you have a government that is either failing to act or actively causing harm, as in the case of the Bolsonaros and Trumps and the authoritarian strongmen in other parts of the globe, do you think physicians have an obligation to go a little bit beyond their normal kind of advocacy for their patients' best interest and actually call for new government and get involved in more traditional partisan politics? Obviously, I know this is a contentious one and it's a case-by-case scenario, but if your government is failing and it's not allowing you to do the best for your patients, what is your obligation as a physician in responding to that?
So I saw the question was addressed to Dr. Jorge, but Dr. Kloiber also wanted to comment. So who would like to start? I think to you, Otmar.
Thank you. Well, I think there is no role for us in doing politics to the extent to explain people whom they have to vote or which government they have to get rid of. I think that's a very dangerous ground, and we should be very careful with that. By the way, we will find in our own constituencies that the constituencies are split as well. But another thing is what I'm currently arguing for in the discussion about the International Code of Medicine is that we should have an explicit sentence in there that physicians should not accept or must not accept medical instructions from non-physicians. Oh, some people say, oh, this is arrogant. You know, there are other people who understand something, scientists and so on. Yes, other people can advise physicians. I have been working in multidisciplinary teams for a long time with physicists and biochemists and so on. Of course, I take advice from those people. I take advice, and I have done so in my early days from the head nurse telling me how things are being done. Of course, you would be crazy not to accept that advice. But that is something different. It is that those politicians, having absolutely no insight into medicine and no scientific knowledge and no medical knowledge, they should not be allowed to tell a physician what to do and how to treat people. And that is something we should proactively say and speak out to. But I would be careful in engaging into political recommendations. Most of our societies don't have that in their mandate, by the way. So we have to be careful with that. On the other hand, I know that many of them do, but I would exercise strong cautions with that.
Well, starting from the last words of Otmar, unfortunately, medical entities in Brazil are very much engaged in this polarization. There is no room here for, among the physicians, which usually is a very conservative body of people. There is no room for any kind of, I would say, to contest and to opposite to these government measures in terms of what the government is doing. But on regards, particularly to this issue of chloroquine to be recommended to everybody, we saw lots of people, lots of physicians and medical entities opposing to this recommendation and making this very much public. Interesting is that governors from most of the states in Brazil are opposing to this recommendation and basing their, measures on what is recommended by their medical personnel. There are many governors that put out a kind of cabinet of crisis, and there are many health professionals in this body, and they are listening to these people very carefully. So I think as far as we can, we are trying to push to more reasonable, recommendations, and to even to opposite to this kind of guidelines that the federal government has just published. But we have also to take care of our young democracy in Brazil. So we are not we do not have a parliamentary system in Brazil, so it's very difficult to remove someone that we think that is taking actions against the public health interest. But as Otmar has said, we have to do that very carefully and to not mix, our, practical way of acting as physicians with our, political positions as citizens of the country. Sometimes this is mixing here because of the confusion situation that we are facing, but I am always trying to push my organization in Brazil, the Brazilian Medical Association, you know, to act reasonably. And our specialized societies in intensive care, in infectology, and some others are opposing to this kind of guidelines publicly. So I think this is good to, you know, take the situation to a more reasonable consideration by the individual physician when they are acting, you know, in front of a particular patient. Thank you.
Thank you, Dr. Jorge. Dr. Montgomery also wanted to comment. You're muted.
Just very briefly, first of all, on the issue of chloroquine or hydroxychloroquine, there has the first RCT study has only been published recently. I don't know, it was yesterday or the day before, on JAMA and New England, I forget. But that shows very, very clearly that it even endangers patients. So there we have a scientific evidence we can quote. The second issue is something which Otmar already mentioned. We must not forget, within our constituency, we have a lot of very peculiar people who call themselves physicians and who are actually qualified as physicians. For instance, the head of the movement that says there is no pandemia, it is just a virus like any other, it's a sort of a special type of influenza and everything is taken far too serious, is a physician here in my country, my home country. And what annoys me is looking at the situation in this country, more than 80% of the population believe that the lockdown and the measures of the government are serious and well done. And there is only a 13% minority led by these people, but with the inclusion of some very right or left-wing extremists who say it is all bullshit, bad, it should be. But we live in a state of a sort of a minorities take over the government. I mean, it's a dictatorship of minorities because they get so much more public opinion and they get so much more public attention that for us, it is sometimes difficult to go through with scientific arguments. But Mike mentioned one word which I got very much irritated by, and that is partisans. I think one of the WMA's core issues, and what makes it possible for us to have Chinese and American, German, and from wherever though in the world, organizations under our umbrella, is that we do not deal with politics or ideologies. We are physicians. We're interested in dealing in the interest of patients. I think this is one of the things we must not forget. Each and every one of us, of course, has their own opinions, and that is good. I mean, Mike, you and I, we would probably be on the same line in all issues. It would be very boring if it was so. But that is something we have to consider. But we have to keep out, we must not go into partisanship. Within the own organization, yes, that's fun, but not towards the outside. Towards the outside, we are physicians and we deal and treat on a scientific basis.
Thank you for those comments. It's a very interesting place to discuss the tensions between science and politics, because we've seen with the COVID, the fact is the science is sometimes lacking behind the moment when political decisions need to be taken. And I think that's normal in all contexts, but I think that there's a difference between political decisions and medical decisions. So
yes.
prescribe, yeah, go ahead.
If you just allow me one word, in a Austrian-German TV show, I was asked the question what I as a physician thought about Donald Trump taking chloroquine. And my answer was, I'm a radiologist. Don't ask me. You better ask the psychiatrist.
So, Dr. Jorge, any thoughts on that one?
That ended. Sorry, Miguel. I didn't mean you. But that ended up in a shitstorm. If you would see my mail account, I have now opened up a separate mail account for this type of shit mails. Sorry, Otmar, I called it WMA at Montgomery.de. This is where all the shit goes in now. But it is amazing, and it is amazing the sort of threats you get as a simple physician if you sort of tell your opinion and be a bit jokey or funny about it.
Thank you. And I think another important comment that was mentioned is basically how taking a contrarian position or a minority position sometimes in the current situation gives you more attention in the media and in the public space, and you can sometimes have more influence by taking something that's more crazy as a position, which is somewhat unfortunate. I have a couple of people who wanted to speak, and we're coming up towards the end. So I wanted I'll give the floor to Marie, then to Maki, and then there's a question in the chat that I'll read out, and then we can discuss those, and maybe in the remaining 10 minutes, and maybe if everyone who's connected, we now have 32 people connected. If everyone's connected wants to turn on their cameras towards the end, we can take a nice group selfie as we do in the current times, and then we'll close in about 10 minutes. Marie?
Thank you, Yassen. Hi, everyone. My name is Marie, and I'm a medical doctor and pediatrician in training in Denmark. And I have a question that's more related to the secondary and tertiary effects of COVID. So as we all know, and as we've seen, especially in pediatrics, that the lockdown has caused much ongoing treatment to stop, we are now starting to see late diagnosis of very serious conditions such as meningitis, and we're also seeing a lot of children that are suffering with anxiety and exacerbations of mental health conditions. And I just wanted to hear what you all thought is the role of physicians and of the World Medical Association in making sure that we treat our vulnerable populations appropriately during pandemics and lockdowns. Thank you.
Maki, I'll take a series of questions. Maki?
Oh, thanks, Yassen. Just a follow-up question. As we've said earlier on, I mean, the COVID epidemic, in terms of peaking in the curves, is now moving more to the global south, and the global north has already had most of its peaks. And you've seen with it, there's been a shortage of for intensive care equipment, ventilators, and there's a lot of morbidity and mortality related to that. And the question is, will the International Code of Medical Ethics touch on the decision-making in terms of now who gets what ventilated, that medical ethics part? I mean, as your medical ethics officer of the junior doctors, is one of those things that I think we should clarify. And with that being said, will there be a new chapter or maybe an amendment to the current handbook that we have, which we use, and I share with our junior doctors wherever, about the decision-making where both patients are healthy, but now it's COVID, and now who gets what ventilator? How do you make the decision? Because they're both kind of okay now. It's just a virus we've never had encounters with. Thank you.
So we're getting the easiest questions at the end, I can see. There's also another question from Santosh. You can unmute yourself and go ahead.
Hello, I'm Dr. Santosh from Nepal. I'm currently working in one of the primary healthcare centers. First of all, I'd like to tell the situation of Nepal. In Nepal, so far we have got 580 cases, and out of them only 3 people have died. But on contrary to other countries, all the people are younger generation people. So this trend, maybe it is somehow different, and I would not like to talk about PPE and other problems, because I think every country are having those problems. My question is, this virus is entirely new, and there could be more such problems because of the climate change, environmental impacts, and other issues like antibiotic resistance. How does World Medical Association is prepared for tackling this situation in coming days? Because it's not just the COVID, but maybe we should get prepared for upcoming problems in coming days. So it is a kind of suggestion as well, and I'm sure you must be preparing something, so I'd like to know about it. Thank you.
And lastly, I'll read out two more questions from the chat. Is there any strategy to extend PPE supplies in every country? I think that touches upon some things that were already mentioned. And what are the strategies for working without adequate PPE and returning home? Oh, and sorry, and there's Nishwa who would like to ask one last question, and then we'll bring it back to you and maybe go slightly over, but not too much.
Hi, everybody. So I'm a doctor from Pakistan, working in a tertiary care center. So my question here is that currently our government, like other governments, are debating whether the lockdown should end, not because it should scientifically end or not because the pandemic is over, but just because they're afraid of the economic recession that's going to hit. So in a situation like this, in a country which has not even reached the peak, opening or ending the lockdown is very dangerous. So do you think that physicians, even if they do not want to be political, can come forward and speak against it, speak against the lockdown ending? Or do you think, what do you think would be the role of physicians here?
Thank you, everyone who had questions. So we have a question on vulnerable population, one on the International Code of Ethics, one on other issues, climate change and AMR, one on PPE, and one on speaking out against certain political decisions that have health impacts. So I'll let you start. I think you don't need to all comment on each one of them, but whoever feels more interested in one of them can pick it up. Who would like the floor first? Okay, go ahead.
Someone has to break the ice. And the last question, I think, is a very important one. On the question on when are we fit to lift, to go from the lockdown to an ease up. And this is, of course, in the industrialized countries of the West, this is a very, very important question now. They think they are past the pandemia. They don't know that as long as the pandemia, the virus is around in the world, easing up and letting people travel between countries may bring it back very, very quickly and may lead to a second wave. At the same time, we have to give credit to our politicians who have to decide this, because they are in a very difficult position. You can take that as a trapeze. There is in one corner, you have the question of health. In the next corner, you have the question of economy. Then you have the question of socio-ecological factors, and you have the question of basic rights. For instance, in Germany, we have a very important issue, whether you can enforce tracking apps, or whether you can enforce vaccination if there is a vaccine available. Now, politicians have to decide within this trapeze, come to the right decision. And of course, public opinion wavers from one extreme to the other. When COVID started and when people were afraid of it, and when we in Germany saw the coffins in Italy, France, and Spain, everyone thought only of health and took it for granted that economy had to be brought down a little bit. Now, we have this paradoxon of prophylaxis, that if we are good in telling the people what they should not do, and if we are successful, then they all say, oh, you exaggerated, you overdid it. If we had not been successful, they would have said, you're mad, you made a bad job. So you can never win in this situation with prevention. So now we see in many countries a swing towards economic questions. And I think it's, at least I consider that to be my obligation in this country. And that is why I get a lot of nasty emails and bad conversations with politicians. I tell them, don't ease up too quickly, don't ease up too fast, because a second wave, it will be much more difficult to lock down again after you have eased it up in a second wave. And of course, at present time, the economic leaders in the Western industrialized country are very strong. And if a president like this wonderful person in the United States of America is even helping them, then it becomes a problem. So that was an answer to the last question. And I would, if I may just say very briefly, the secondary effects and tertiary effects, which Marie mentioned, very important question, very important question. And it has two aspects. The first was, at the beginning of the disease, we even ourselves said, don't come to hospitals with minor diseases. Wait until we have capacities. But the second is also this question of stigma. People don't come to hospitals or don't go into pharmacies or into the operating rooms of physicians because they are afraid that they might contract COVID-19 or SARS-CoV-2 there. And there we have to be very, very clear that we try to do everything to protect our patients. But interesting discussion, and all this will be worked out by scientists over the next few years. Interesting discussion is going to be, are eventually, in the end, more people killed through the secondary effects of non-prevention, of late diagnosis, etc., than that would have been killed had we let the whole disease run. But as physicians, I think there was nothing we could do else but try to treat this as much as we could.
Thank you. I'll give the floor to Jorge or Dr. Jorge or Dr. Kloiber. Please keep your remarks short as we're now running over time, unfortunately with the nicest questions or with the most elaborate question set.
I would just I will skip the questions that Monty has commented for due to the time. I would like just to comment on the lack of PPE and the other side of this. We are, I think, facing in many countries in the world a lack of intensive care equipment, particularly this personal protection equipment, which is responsible for many of physicians and other health professionals, particularly nurses, to be infected by the COVID-19 and put in a kind of quarantine before coming back to work. But there are also a lack of intensive care beds for the population, and that's the reason for these social distance measures, trying to slow down the curve and not everybody arrive at the hospitals at the same time. And what we are seeing now here in Brazil, besides this situation, is that even when you have PPE enough for the people, as we are enlarging the number of IC beds, there is a problem, which is the lack of health professionals with experience in working with intensive care units. And some of these people is being infected when they have to take out a PPE to take another one, when they're changing from one side to the other, from one patient to the other in the IC units. So I think, this pandemic is put into the eyes of everybody problems that we have in our health systems for a long time, lack of equipment, lack of personnel, lack of, good public health policies, lack of everything. And I think that one of the documents that we release on behalf of the World Medical Association approach this issue, what is behind, what is coming with this pandemic, what is this pandemic is revealing to everybody. So I would just make this comment and leave the word to Otmar for the next comment. Thank you.
Thank you, Dr. Jorge. And maybe I can now ask everyone to turn on their cameras, and we can get, while Dr. Kloiber is doing his final remark, we may be able to get a photo of everyone, please.
Thank you. So that leaves me with the questions about the rationing, triage, global fairness, and then the question whether that goes into the International Code of Medical Ethics. Let me start with that. No. The International Code of Medical Ethics is a deontological code which directs the individual physician. So the questions of global distribution, for instance, and questions of triage cannot be in detail be addressed in that. But we have policy on that, and we have policy which is giving you already some guidance. And we have also acted on that during the past weeks. For instance, when it came to the question of PPE, we immediately have said this is also a matter of global solidarity, because we know the rich countries are able to fish from the market and to pay the highest price for everything there. But that means we have to put WHO and other help organizations into a position that they can help to fill in some of the gaps. And we probably also will have to continue arguing, which we have been doing in the past, for a much fairer trade in this world, but also for a much more regionalized production of those goods. And fortunately, some of this is going on. I've learned from this from Kenya and from Uganda that factories are starting to produce PPE themselves now in order to serve their own markets and African markets. And that has to continue and has to go on. The problem is we should not forget about this. The very difficult one is the one on the triage. Now, again, I said this has not been part of the ICOME and will not be there in detail. But the Declaration of Geneva already gives part of the answer, because the Declaration of Geneva tells you that you cannot act with unfair discrimination. So, for instance, what we have learned from some parts in the world, that they said, oh, you are over 80, you don't get an intensive care unit treatment. That is not permissible according to the Declaration of Geneva, because it says that you will not discriminate somebody because of age. It's very clear in there. It's in there already. It says that we don't use unfair discrimination, which means you have to look for medical reasons. In the 90s, the WMA had an own policy on triage, which was very detailed, explaining the triage. And unfortunately, I don't know why we have given that up. We have now a policy on the disaster preparedness, which only demands that each nation has its own policy on triage. And I think that is something which we have to insist on, that people think before a disaster and before a pandemic, that they have something in place which they all can agree on, and which is based on medical discrimination, on a fair discrimination, on medical grounds, and not on things like age or income or availability just because of social status or something like that. So this is something which we have to work on and have to continue in the time after the pandemic, that really these rules are being there in place, and that we don't have to start thinking about it when the disaster comes. That is something which we do. And I think we also have to advocate in the future for what I said, the more regionalized production. It's, by the way, it's not only PPE. We also see that drugs, medicaments are missing, because we have a very high concentration now for some of the active compounds on 1 or 2 companies in the world. And if those companies, for whatever reason, says, well, we stop producing them, these drugs are missing. And that reaches from everything. That reaches from blood pressure medicaments to antibiotics to contraceptives. Everything is now at stake with that. So we really have to rethink the way we distribute, we stockpile, we finance the supply of healthcare regionally and globally. Thank you. Yassen, back to you.
Thank you, Otmar. Given the time that's running, I would like to conclude this session. Thanks everyone who turned on their camera. I think it's, given the format, it's probably one of the largest pre-WHAs turned into a post-WHA. So thanks everyone for attending. Mike, to you.
Mute myself. Thank you everyone, and thank you Miguel, Dr. Montgomery and Otmar for brilliant comments, and it was really interesting to hear the WMA's perspective on a range of issues relating to medical ethics, the politics of the response, and the role of WHO.